So thanks everyone for joining us today. I'm Amy Gardner, Associate Dean for Faculty Development here at CU School of Medicine, also Director of the Academy of Medical Educators. We're delighted that today, July 11th, 2024, we are relaunching our Education Grand Round series that we are going to be hosting every second Thursday of the month at noon, always virtual to promote inclusivity and let folks kind of dial in from afar. So thanks for joining us, and thanks for your support as we relaunch this series. I'm putting in the chat right now just a link to our Ed Grand Round schedule for the rest of the year. I actually see some of our future speakers on the call, so thanks for joining us and checking us out. We have a cool lineup of all sorts of topics, everything from creating inclusive learning environments to mentorship to communicating your science to the general public to gossip in medical education, which I think will be an extra spicy Ed Grand Rounds. Lots of discussion, I hope, for that one. So please mark your calendars and join us for those events. If you are not already receiving Outlook invites for this event and you wish to, please just put your email address in the chat, and we'll make sure that we add you to future distributions and Outlook invites for announcements for this series. But today we're excited that we have the pleasure of hosting Dr. Eric Holmboe, who's going to be talking to us about addressing and reducing bias in assessment for health professions education. I think we're all probably pretty familiar with Dr. Holmboe's work, but as of just earlier this year, he's now the Chief Executive Officer of Intel, which, as you maybe know, includes the ECFMG, the Educational Commission for Foreign Medical Graduates, as well as FAMR, the Foundation for Advancement of International Medical Education and Research. So Dr. Holmboe would love to hear a little bit about that transition and how it's going so far. But as you likely know, Dr. Holmboe has spent a substantial amount of time at the ACGME, where he was a mover and a shaker. So at the ACGME, he was Chief Research Milestones Development and Evaluation Officer, where he supported the development and implementation of over 180 sets of milestones. So I see our prior and current deans of GME on the call, so you're very familiar with his work. Dr. Holmboe, during this time at the ACGME, also created the Advancing Innovation in Residency Education program, co-led the development of multiple guidebooks and national reports, supported a number of faculty development programs and toolkits, just to name a few, but I really could go on and on. Prior to the ACGME, Dr. Holmboe previously served as the Associate Program Director at Yale Primary Care Internal Medicine Residency Program, Director of Student Clinical Assessment at Yale, as well as the Assistant Director of the Yale Robert Wood Johnson Clinical Scholars Program. And prior to Yale, he served as the Division Chief of General Internal Medicine at the National Naval Medical Center, and ended up retiring from the U.S. Naval Reserve in 2005. Thank you, Dr. Holmboe. And among many other national, international roles, also served as the Chief Medical Officer at the American Board of Internal Medicine from 2009 to 2014. So I think I've adequately convinced all of you that he knows
way
assessment.
More than needed, but thank you. Very kind.
Yeah. So I'll turn it over to you to Dr. Holmboe, and everyone else, if you're just joining, if you want on the distribution list for future Ed Grand Rounds events, put your email in the chat. And periodically throughout, I'll be putting the link to our Ed Grand Rounds quick 3-item evaluation survey in there as well. So would love your feedback on how this went and any other feedback you have. So without further ado, Dr. Holmboe, the stage is yours.
And can everybody see the slides, Amy? Give me it looks okay?
Perfect.
Fantastic.
Yep.
Well, thank you for the opportunity to do this. I had the good fortune to visit Colorado a few years back, and it's just such a lovely place to be. And thank you for allowing me to talk about a topic that I think is really important, and honestly hasn't gotten enough attention until really probably the last 5 to 6 years. And this one's particularly important to me in my new role, because we know that many of our IMGs, particularly those from other countries, often face various forms of discrimination, bias, and so forth. So this is very much also front and center for us as an organization, particularly given that 25% of all residents in the US at any given time, are international medical graduates. So they're a substantial proportion of not only the GME workforce, but also it's about the same percentage of practicing physicians or IMGs as well. Just real quickly, these are my disclosures, and I do want to highlight that I've been doing some of this work over the years with Dr. Dowen Boatwright, now of NYU. Strongly recommend anything Dowen writes on bias. It's a tremendous group doing great work, and so I've been really privileged to work with him over the last several years. So let me just kind of lay out the agenda. And in here, I'm going to insert some reflection questions that we can do kind of through the chat, or that you might just want to kind of make some notes for yourself on where you're kind of sitting. So first is, what is bias? And then we'll talk on kind of what the research on bias and assessment is. And I'll kind of show you where the kind of state of the art is, what we know, but more importantly, what we don't. And then I'll share a little bit about interventions and approaches that we can all use to at least try to mitigate bias and continually improve the system. So what's bias? Well, there are several types of bias, and I think it's worth kind of reviewing those for a moment. The first is called structural bias. And this is really at the institutional level, such as medical schools, hospitals, et cetera, that engage in patterns and practice that advantage some groups and disadvantage other groups based on their personal demographic characteristics and identity. And so this really represents a group level effect produced by institutional behavior and norms. And then there's explicit bias, and typically folks define this as conscious beliefs and attitudes one possesses about another person or group. A good example, a kind of obvious example of this would be the Ku Klux Klan. And their kind of explicit beliefs about people of color. Implicit bias is a little different, and this is, we certainly have explicit bias and structural bias in medical education, we know that. But implicit bias is probably something that on average we see more of. And implicit bias is an individual's prejudicial attitudes towards and stereotypical beliefs about a particular social group or the members who are part of that group. The challenge here is that the reason it's often labeled as implicit is it tends to be subconscious. And so as we break it out between prejudice and stereotype, what we're referring to with prejudice is that it relates to negative attitudes individuals form toward other persons or group, often in advance or without any actual experience or exposure with the affected individual. So many times you'll hear that part of the problem here and why prejudice on these kind of negative attitudes is because folks have never had any, if you will, experience or contact with other. You know, if you're living in an area that is predominantly one ethnic group or the other, you may have not had contact, and therefore you form negative attitudes about them based on how you were socialized growing up, what you see on TV, social media, and so forth. Stereotyping is a little different, and they're obviously related, but it refers to rigid, fixed, overgeneralized beliefs about a specific group of people without any actual experience with the affected individuals. And so that's, like, I'll give you an example that we actually saw in a direct observation. We researched, we had a scripted encounter where a resident was essentially telling an older gentleman that he had an STI and that he'd acquired that STI in an extramarital affair. The individual was of Indian descent as an Indian in the country, even though they themselves had grown up in the country. And we saw a number of faculty subconsciously as they were viewing this videotape, and it was scripted for the resident not to break this news well, right? It was not a good performance. And we heard things like, well, in their culture, they're uncomfortable talking about sex. And so that's stereotyping the entire culture based on an overgeneralized belief. Now, where that came from, we don't know. But that's kind of fascinating if you think about it. Like, you're watching a videotape, and yet you're stereotyping this individual based on your belief about an entire country, which even in itself is not a monolithic culture, right? There are many cultures within India. So that's an example of kind of stereotyping. What's important to know about this is that when we engage or carry bias or these type of stereotypes, they will affect what we attend to when we're watching our learners and teaching them, the impressions that we will form about them, and also what's interesting, what we encode into our memory. So if you think about, I'm watching a particular trainee of a particular ethnic group, and if I carry some bias or have a stereotype about them, and I watch, for example, an observation, and sometime later I go to fill out the assessment form, what I've carried in my memory from that encounter, what gets translated at a little bit distance time, is affected by those bias and stereotypes, but what I've encoded, what I remember when I fill out that form. And there are lots of things that really affect whether or not implicit bias or stereotype or prejudice gets expressed. One is just your emotional state, right, that you happen to be in. Time pressures can lead to, particularly if you're under time pressure, you might be more likely to engage in implicit bias. Circadian rhythms, it turns out even like the time of day and your rhythm can affect it. What's your motivation when you're going into the assessment? That can affect it. And of course, if you have existing explicit prejudice, that's going to play a role. And then, as Peter Yates from Keele points out, your cognitive preferences, but how you approach a text, even that can affect what type of biases you might engage in. Now, this is particularly important for implicit bias because, as I said, they're mostly subconscious. But what we've learned, and again, a limited amount of research, but kind of pulling from research from other fields, if you simply tell somebody not to do it, hey, don't do that. Don't, engage in gender bias or, bias against a racial ethnic group, it doesn't work. In fact, some research has shown it makes it worse. It's what researchers call a threat intervention. Simply telling somebody not to do something turns out not to be terribly effective. And we'll come back to things that are more effective in just a little bit. But I just kind of wanted to tee this up so I have a sense of kind of what we know in this space. So what I'd like you to do is I'm going to give you a minute or two for this. I want you to think about the most recent episode of bias you witnessed in assessment. What was the context in which that happened? Do you know what the impact or consequence of that bias was? And if you see it, do you feel comfortable addressing a bias either with the program leadership in which you work or with that colleague in which you just saw the bias occur? So spend a couple minutes, if you would, just thinking about that. And then for those who are willing, I would love to see just some reflections in the chat. We'll just give it a couple minutes, but please take a moment to reflect on these questions. And if you're not comfortable putting something in the chat, or you would actually like to say something verbally, is anybody willing to kind of share an experience they had? Again, without calling out any specific individuals by name, but just a general experience they had. That would they be willing to share that?
One thing that I think that we've talked about in a couple of venues recently is kind of written evaluations, like end of rotation evaluations and the like, and kind of strategies and steps that people can take to maybe reduce bias, but at least just to get them to pause and reflect of when you're writing these evaluations, what assumptions are you making? So maybe it's how someone's communicating, and is that, based on kind of maybe their culture or prior other experiences, making maybe assumptions kind of based on a gender level around kind of specialty choice or future specialty career directions and things like that. looks like Dr. Bilyeu has her hand up with maybe a good example.
Well, can you hear me okay? I've got weird headphones in. Okay.
Yeah, keep going.
Yeah, well, I was just thinking, so I'm in the physical therapy program, so
Okay.
lots of practical examinations throughout our curriculum. And I lead a lot of those with our first year students. And so we work on trying to train and prepare our instructors for assessment. And one of the things we encountered last year in an exam was sort of bias related to a student's past performance and professional behaviors, and not allowing space or acknowledgement that the student, had been actually working very hard on those things to have professional behaviors come across in a different manner during these practical exams. So coming into examining a student based on how their past performance and behaviors were in the classroom took some time to work through with instructors. And to answer sort of the third bullet, as a team, so far, we have felt comfortable in addressing that as a team and talking about, how we can mitigate some of those things to just level the playing field in assessment for our students.
Awesome. Well, thank you so much for sharing. I mean, again, it's an uncomfortable topic, right? Because we certainly all want to feel like we're not biased, and yet we all as humans have blind spots as well, regardless of our best intentions. So what I'd like to do now is just share with you a little bit about what we've learned. And this is not a complete list, but it'll kind of give you a kind of, state of the current art, if you will. This is a slide again from Dowen, and I'm sure that you've probably heard about this paper, but it really gets to what you just talked about, Amy, and kind of the written evaluations. And so this study actually found that there were differences, that in this case, white applicants, and this is the medical student performance evaluation in applying for residency, were more likely to be described using standout keywords like exceptional or best, while Black applicants more likely described as competent in those letters. And then, we often see gender-laden type language that we should be careful about, where female applicants in this study were frequently described as caring and more empathetic. And so again, it's not that, for example, the descriptions of the women applicants may not be reflective, but the question is, was that being used because they're woman instead of really other types of assessment evidence, if you will. This is another paper from 2017, again, from Dowen's group, just kind of showing students who report experiencing bias in their assessments. And you can see that the underrepresented and medicine minorities, which is kind of an aggregate of Black, Hispanic, Native American, so forth, had the highest reported percentage. And then Asians were next, and you can see that with regards to the white students, it was below 1% in any given rotation. Part of the reason this is so important, even if it's implicit or it's something like what I just showed you in the narrative, and I'll show you in a moment why this particular concept is so important, is something called the amplification cascade. I really like this paper from Ariane Tarani and colleagues. And what they found is that even small differences in how folks are assessed can actually then create what they call the amplification cascade, where they may not get the same grades as their peers. They don't get as many awards. And it tends to reduce their opportunities, particularly, for example, when they apply for residency. And so I think it's important to keep this concept in mind that we could look at a difference. Let's take a 9-point scale, and a white student is rated as kind of a 7.9, and the underrepresented group 7.5. And if you look at the standard error, it doesn't really appear to be that much difference. You're like, well, it's a little bit lower, but is it really that big of a deal? And it turns out that it is, and it certainly can be. And so even those small differences is often a signal that these folks are not going to get the same opportunities. Now, I'm going to talk about what we've learned in the GME system. As Amy said, this was a part of the work, and I continue to work with ACGME. This is what the kind of overall assessment system looks like. So if we start on the left-hand side there in that gray box. Typically, residencies use some combination of these assessments. These assessments generate data that comes to a group, the clinical competency committee, that then makes a developmental judgment. In our system, those are the milestones, right? You know, where they are in their trajectory. In an ideal world, that information from the committee is fed back to the resident in a sit-down conversation with a trusted advisor, program director, and so forth, in order to help them generate an individualized learning plan. And then that information should go back to the faculty, the program directors, and so forth as part of their program evaluation activities so that they can make changes to the assessment system, but also better prepare folks in performing assessments. And then on the right-hand side is essentially the regulatory system, accreditation, certification, and so forth, with the public being the primary constituency. But what happens inside this rectangle is by far and away the most important thing. Yes, the accreditors and certifiers have to design their assessments appropriately. We know that even they have uncovered challenges. For example, pediatrics went and took a look at their item bank for the certification exam, and they found evidence of bias in some of their questions when they actually went back and looked. And so those questions are removed. So we on the kind of regulatory side have a role to play as well. But the really biggest impact comes from the educational program, whether it be in medical school, residency, or fellowship. And the reason this is important is that this is what a learning curve actually looks like. This is based on wonderful work from Martin Pusick, who's actually measured these. And learning curves are sigmoidal. And as folks move up that curve, what tends or should happen within the program of assessment is that we should shift from this kind of heavy reliance on things like multiple choice tests or things like OSCE, which clearly have their role, to a greater emphasis on how they actually performing. In other words, what can they do when they're caring for patients? And so as we get up the curve, particularly in GME, that does part is critical. We often refer to that as work-based assessment, and that is almost always done by faculty, particularly physician faculty, but there may be others, right? They observe and they make assessments and judgments. And so it's during this particular phase, and including medical school, where there's still a fair amount of does going on, where we know that bias can be a real challenge. And so just a quick reminder, here are the milestones. They're based on the Dreyfus stage model development. Our goal is to get folks to proficiency, which is coded as level 4. So how has that system been performing? So now that we've put in a developmental type rubric, hopefully to better give us a trajectory measurement, right? So we can see how they're doing along the way. How are we doing? And I think it's always an important moral imperative that anytime you make a change to the system and you study what's happening with it to make sure that you can make it better and uncover problems. So there's some good news, and this is a study that literally just came out a few months ago where Bradley Gray and the crew at the American Board of Internal Medicine compared the milestone ratings. In this case, they focus mostly on knowledge with regards to the milestones versus what used to be the old system. So I'm a general internist, as you heard, I was at ABIM, and up until the milestones, program directors each year had to come into something called the fast track system and give a judgment on their residents using a 9-point scale that ran from unsatisfactory to superior. And then, there were various competencies that were rated like history taking, physical exam, medical knowledge, and so forth. What we found is that the milestone system ameliorated bias against all groups except one. There was still substantial rating bias, interestingly, that was found for US-born Black residents that persisted. Things did get better for that particular group, but it did not close the gap. And here's the actual data. Well, this is the old scale, and this is converted to a Z-score. And the milestones, and this in the case is kind of lumping the underrepresented group. And you can see there was substantial improvement, and it actually got again, this one kind of outlier here, but it got progressively better. And there's still work to be done, but at least by thinking more developmentally, using more narrative, it did help kind of improve the situation. And what's interesting, when I was at ABIM, we never knew this, which is kind of fascinating, right? And to be honest, we looked at bias, we didn't look at it through this lens, but we didn't have a comparator in which to do it. And this is what I talked about, where US born Black residents, you can see things got better, but they're still lagging if you take a look at the kind of, comparison line, the zero line here. Interestingly, if you were non-US born Black resident, you can see that that also got much better and the gap was actually closed. Not sure exactly why this is happening, but this is, again, concerning. So partial good news that a developmental system helped compared to an older system, but we still have a lot of work to do. We took a fair amount of look at gender bias, and so looking at that as kind of a separate issue, and we didn't really see any evidence, again, using comparators in internal medicine ophthalmology. Both those studies have been published. And then there were mixed small effects in emergency medicine and general surgery. But remember what I told you, even though the mixed small effects were by subcompetency, we don't know if there's still a problem with the amplification cascade. And then these were not yet published, but we looked in family medicine and pediatrics where we didn't find evidence of bias either. Interestingly, both of these fields are predominantly women. And so family medicine is around 54 to 55%, and in pediatrics is 70% women. In peds, there appeared to be a slight advantage for women, if you will, but that actually might be appropriate just given that 70% of the cohort is in fact women. This is, however, another study from internal medicine that looked by just purely race and ethnicity. And again, this is from Darwin's group. And they had to collapse certain groups. So that's a little bit of a challenge because they had statistical power issues. The other thing that's important to recognize about the study, this is only US allopathic grads. So this was data that they were able to pull from the AAMC so that they could get more of their racial and ethnic background more accurately than what ACGME had at the time. And there's this kind of interesting phenomenon. So that for both the Asian group and the underrepresented group, there was this kind of trailing lag through the first 2 years. Maybe not so much in the first year, but the bottom line is both these groups were kind of a bit behind where the white residents were. And then in the third year, interestingly, they essentially, you can see, catch up. And so there aren't really any differences. And so you're like, oh, that's great. That's good that they ended up in the same place. But remember what I told you about the amplification cascade. And also remember that these residents are applying for fellowship in their second year. And so again, although these may look like small differences, they may have major impact on what's available or what opportunities these residents have with regard to applying to fellowship. And that's important in internal medicine because 2/3 of residents, give or take, will pursue fellowship training. Well, it got even worse than an emergency medicine study. This was the first study to look at the intersectionality of race, ethnicity, and gender in emergency medicine milestone ratings. And so again, this work was led by Dallin Boatwright's shop. This is the kind of distribution. About 1/3 of the residents were female, 128 emergency medicine programs. This is the breakdown of the 3 groups they looked at, where you can see this particular specialty is predominantly white, and a smaller percentage of underrepresented, again, collapsing all those categories I talked about. And this is emergency medicine. And what they found was that when they actually included as a covariate their performance on a licensing exam, it didn't make any difference. That particularly for underrepresented minorities who were female, the gap between themselves and their white counterparts progressively got worse. And if you look at medical knowledge, this is a resident in a 4-year emergency medicine program. The milestone difference was 0.75. Remember, the milestones is 5 levels with half increments. So anything that's 0.5 means that you've shifted a whole box. And so this is very sobering. We're in 3 of the competencies. They are essentially around a whole unit of analysis or evaluation compared to their white peers. And practice-based learning improvement, professionalism, and the most profound was actually medical knowledge. So this is very concerning. And to the credit of emergency medicine, having worked in that field, they took a look at this and said, OMG, we need to do something about that and better understand what's happening. And again, underrepresented males were also, you can see, lower on a regular basis, Asians as well, even white females in some areas almost reached significance, but on average, there was no difference between them and the males, white males. So, again, highlighting that in some areas we probably are doing a little better where we were, some areas we're doing better in gender, but we've got still real issues even in using this new system. So I'd like you just again to think about, as we just did a minute ago, how do you detect and address assessment bias in your own program? So Amy, I heard you say that you've talked about it and things that folks can do, but do any of you have monitoring systems, if you will, to take a look at your data, even just looking at basic differences over time to see if there's any signal in the ratings or assessments you're doing? So is anybody doing that?
This is Ty Lockspizer from the School of Medicine. I'm in my car driving into clinic, but did want to highlight that we do a lot of work in this area with our medical student assessments, which I've sort of talked with you about a little bit. And
yeah, nice to see you. I'm sorry hearing you, Ty. I realize I can't see you.
About that, I'm like just getting to clinic, and so hopefully we'll be able to get onto my camera. But this is something that's huge for us and really is something that we've been watching, and we're very curious in the School of Medicine as to what the impact of going to an all LIC curriculum will be in terms of sort of closing that gap. We've had some data over the previous years showing that things are getting a little bit better, but obviously not eliminated. And so continue to follow it really closely. And then Wendy and I are working on a larger national project with 6 other schools to look at the structural factors predictive of inequities in grading and clinical assessment. So yeah, we're very interested in it. I think it's also comes up for me when I'm reading a lot of the assessments that get submitted about our students and asking that question, and sometimes sending it, like going to the faculty and asking that, or even in the grading committees have brought up, could bias have been playing a role at all in this comment? And do we want to consider that when we think about what to do with the grade?
Yeah, that's terrific. It sounds like you have a safe space to have that conversation, which is obviously a really important step, right? I mean, if you can't talk about it, it makes it even harder. So that's terrific. I look forward to hearing more about your work. I'm sure you know this better than I, but one of the things I've heard from others working with LICs, people like David Hirsch and others, is that part of the probably secret sauce there is the longitudinal relationship and getting to know these folks. That may be one of the reasons why you see at least some improvement on this front as well. Would you agree with that, Ty?
Absolutely. I think that that's very much one of our hypotheses, because I think that, one of my recommendations for people in terms of combating bias is to find similarities and to really understand that, we may be different, but we're also pretty similar in a lot of ways. And I think that that's much easier to do when you're working with a learner over the course of an entire year versus just a week or even just 1 or 2 sessions. And so my hope is that that is exactly what we will see.
Awesome. And Clint, I love your comment. Do you mind just saying a little bit about it?
Yeah, absolutely. We saw that bias in assessment was a rampant problem across our assessments in a variety of different ways. So we put together sort of these teams of moderation cohorts that would go in and specifically and only look for bias in assessment inside of language. We weren't looking at any other piece of assessment. We were that was dealt by another cohort. So this was dedicated small teams. We tried to make those teams diverse so that they were coming in and detecting bias with various perspectives. And it was really powerful, both in correcting the assessment, but also kind of opening up a larger conversation about how we communicate effectively.
That's awesome. Thanks so much for sharing. So that's a great segue into at least what we can learn from the literature about these interventions that could help mitigate bias. And so I'm going to go back to work Darwin was involved with, but this is actually from Captain Lucy, Karen Hauer, and their team. And so they think about it kind of an interesting model. So what the first they call is process equity or inequity. And so in other words, the process involved in the actual assessment can be a source of bias too. So the first is, what's the intrinsic design of the assessment? In other words, do you put questions or items on there you're asking faculty to ask that may inadvertently be reinforcing bias? The second is the context in which the assessment is implemented. One of the things to remember about any assessment tool, that tool is only as good as the person using it. So I love the way Case Vander Vloot and John Orsini and others talk about it. They say, remember, the person using the tool is the actual assessment instrument. You got to get the assessment instrument right and design it well. But at the end of the day, the largest proportion of variance or differences is going to come from how the person uses the tool. And then the other is called the instrumental use. Like, it's the context, like, is there a supportive environment to which to do this? And then do they have clear instructions on how to perform the assessment, and have they been trained to do so with bias, being called out as a concern? And all of those things can affect assessment outcomes, which then leads to whether or not you have outcome equity or inequity. In other words, from an educational perspective, what is the rating they get on a milestone, or for some now, the EPAs or trust professional activity. So this is important to kind of think about your components of assessment where you can make differences. And then a couple of years ago, we were asked to write a paper as part of a Macy conference. And one of the things that we did was kind of a review on, okay, so we have some sense of what the current state of bias and it's a problem is. What's the state of art and like what folks have done to try to reduce bias and what's been published? And to be honest, that was pretty sobering. We had a very hard time actually finding a paper where folks had actually implemented and then written about an intervention to reduce bias and its effect. What we ended up having to do is actually go into other literatures, one of which was quite helpful was in the patient counseling and informed decision-making literature and what they had learned about how to reduce bias in that process working with health professionals. And so some of this has actually come up. So one of the strategies, something called stereotype replacement. And so one of the things you want folks to kind of think about is that they're completing particularly a narrative assessment. Are they basically incorporating something that's a stereotype? Gender-laden language has a lot of stereotypical characteristics to it. And so part of that is developing the kind of mindfulness or reflection about, oh, I'm using this term that this, this woman resident was lovely. Why am I using that term? Is that a gender-laden term because, I'm not really being specific about the feedback, or was it around something that they actually did? The second is what's called perspective taking. And this is something I think has come up, considering what it would be like to be a member of the minoritized group. And so this is just an example, right? During rounds, we saw this a lot, as you know, during COVID, and you know much more about this than I do, but patient, there's a difficult interaction between a learner and an underrepresented in medicine learner and a patient, and the patient's discriminatory. And one of the things right off the bat we can do as faculty is like, what was it like for that learner? How will I intervene in the situation? How can I debrief with this learner to get their perspective on what that actual encounter or experience was like? And that alone just kind of helps, legitimizes what they just experienced. It provides support for them, right? It's empathetic, but it also helps us learn what it's like for them to go through that particular experience. The other is something called individuation. Recognize when you stereotype someone according to group affiliation, instead of thinking about what makes them an individual, like, I'm stereotyping them because of the XYZ group. Like, no, this is an individual. Wonder what their lived experience has been. Where are they from, right? We are not monolithic creatures. We all have amazing life stories, and learning about what those life stories are, where they come from, kind of what they believe, and kind of what drives them can really help with that. And kind of, again, seeing that as an individual, not as like some stereotypical group. The other is called counter stereotypic imaging, where you start with an assumption, but then you step back and say, wait a minute, can I think of an experience where that stereotype actually didn't hold? And I actually had an orthopedic surgery faculty tell me this one. This person, male, stereotype is that women weren't strong enough to put in hips and knees, right? They didn't have the strength. And then, he said, but I began to think about, no, I had plenty of women orthopedic residents. I shouldn't say many, but, there's not a huge number, but, it had women residents who did just fine putting in hips and knees, right? And so that kind of idea they're not strong enough is kind of crazy. And so the fact that he was at least able to trigger, like, well, that's not true. I've worked with, women who actually do just fine, duh. Believe it or not, can be helpful. So it's kind of teaching folks to kind of do that type of thinking. And then first and foremost, just increase opportunities for contacts is what we just talked about with Ty, and I think the longitudinal integrated clerkship really provides for. But the more that we can learn about their lived experience, the better. And so, even just stuff out of the clinical space, learning about life histories. One of the things that's just been striking for me in my 6 months here, I've had a chance to visit a few institutions. As part of my visits, I asked to meet with the international medical graduates and learn about their experience. These stories are incredible. And these folks go through a lot to get here. And so just having a sense of what their journey was, what that was like for them, is really important for me as we think about how we improve our services, but it also really helps to reduce bias, right? Because some of the bias that they've experienced comes from the fact of what country they come from. There's stereotypes, as I told you, about India and other countries, when in fact these are individuals, who've had very interesting journeys to get here. So anyways, I think that's just important to keep in mind. I like the comment from Amy. Yeah, I'll bet. But these are hard things, and part of it is training us to begin to just be more mindful about these things. Part of the reason this is so hard is when we're observing our learners, these are all the things that are in play. This is from work that we've done around observation, but from the faculty perspective, they bring a number of lenses into that observation. What's their own clinical and educational competence? We've actually shown that does have an impact on how they will judge a learner. Obviously, there's self-efficacy in performing assessment, but they also have their own underlying biases and idiosyncrasies. Sometimes that bias is in the form of a rating error where they're a hawk or a dove, but a lot of times there may be implicit bias that they're just not aware of, and they just need practice. And then we all have idiosyncrasies, and sometimes even those idiosyncrasies may be a form of bias. So that's just a sense. Sorry, I got to pop up there. That's just something you have to keep in mind about faculty. And then, of course, as the learner's interacting with the patient, what's happening in that environment, what we call the microsystem, can also affect whether, remember, bias gets expressed or not. It's that contextual part of the process that Catherine and Lucy talked about. Is the interprofessional team functional? Are members of that team carrying bias? Is there good care coordination? What's the professionalism, of all of us in a particular setting, and so forth? And so there's lots of things that can trigger or affect a bias, but it's something that we have to kind of learn to be more attentive to. So one of the things we did as part of our work is really over the last 10 years is to take a look at really what should the kind of flow look like. In this case, it's really in the context of a direct observation or kind of an encounter or face-to-face. And one of the things we recognize is that use a narrative description first. Don't start with the scale. Start with the narrative about what they did well, what they could do better, and kind of a summary. And when you're making that narrative description, use the best evidence available to you. For example, if you're watching them break bad news, we have good science around frameworks that can help with that, such as spikes or informed decision-making, motivational interviewing, and the likes. You then have feedback with the learner, and you use that evidence-based approach or framework to guide that conversations before ever completing a rating. And I think what we need to get better at is that each stage of this process is to engage in what I love this concept coming out of the patient care literature. They call it an equity pause or a bias timeout. Take just a moment and say, okay, I just wrote this narrative. Could there be bias in the way I describe things based on the demographic characteristics of my resident and so forth? And then when I'm in the process of giving feedback, mindfulness to say, am I using bias and stereotypic language and so forth? And this can be really helpful. And they have found in the patient care space, this actually does help reduce or mitigate bias. Doesn't eliminate it completely, but definitely can help. And so I think this is a technique that we can teach ourselves. And it sounds like, particularly Ty from you and Amy, that you're doing some of this work. You're getting folks to begin to think about, right, develop that mindfulness. And then you might think about even labeling, like, hey, take an equity pause. I always uses the analogy, right, when you show up to a cardiac arrest. I just remember for resident, my program director teaching me, remember, taking your own pulse first. You know, so that you take 2 to 3 seconds to kind of get yourself grounded before you kind of jump in. Same thing here. Take 2 to 3 second pause, think about what it is you're going to say, and be mindful that there might be some bias in it. Part of the reason I think this is so important is I think there's another thing that we can do that helps here. And I've been very interested over the last decade in this concept of co-production, where we actually see learners as our partners. And so when we, you know, do any type of assessment, we do it in partnership. And so this is called the co-production learning cycle. And essentially, you know, once you've performed an assessment, you should co-assess with the feedback in conversation with the learner. Ask them, where do things stand in their development? What experiences were effective? You know, tell me more about how this sounds to you. And then the next step is decide with the learner what's the program and their goals and where we're going to get to next. And then co-design the individualized learning plan based on their goals and the program's goals. And then you go out and you try it and you keep doing the cycle. And each time you do this, it's in conversation with the learner, which is a wonderful opportunity to get more insight into their lived experience, how they're doing, and so forth. Okay? And so that brings us back to kind of thinking about that developmental curve, is to think about that whole journey as a whole series of co-production learning cycles. And at each point along that curve, thinking about what's happening with regards to bias with this learner and partnering with them to help in that journey. And also, as I said, to get a better sense of who they are in the lived experience is one of the key interventions we can use, right? Individuation, learning about the lived experience and so forth to get better. And so this is just a kind of final list of things, and I'll stop here. And, you know, again, happy to send the paper as well. It's open access. But I think it's really important to use your assessment data to investigate, understand, and address sources of bias. And I'm so thrilled to hear from Ty and others that you're doing that, right? We can start to look at, are there differences? Again, it's going to be crude, but that's okay. You know, did the trajectories look different? And then really make sure they have a good sense of program culture and the institutional learning environment on the learner's professional development. Programmatic assessment by having multiple assessors, multiple assessments over time is a good thing. And that can actually help mitigate bias. And then experiment with some of these potential techniques or others that you've been working with to see if it helps. And it's great to hear that you're doing that. I think that's awesome. Like I said, if you've got unwarranted variation in your assessments, try to understand why that is. In other words, do you have some raters that are more harsh than others? And is that harshness due to bias? I think that's an important thing to sort out. Leverage the co-production I talked about. And like I say, you know, confront the inertia and changing your assessment practices, particularly around bias. It can be hard in an uncomfortable conversation, but what I'm hearing from a number of you is that you've made real progress in this area. And that's awesome. Congrats on that. And so one of the things I'd like you just to leave with today based on what you've heard and also from your colleagues, you have resources there at Colorado, some wonderful folks. What's one thing you could do right now to reduce bias in assessment? Either you as a leader or you individually, the next time you go out and assess, what could you try that might help reduce bias or at least gain greater awareness around it? And so in conclusion, bias remains a persistent and pernicious problem. We have tools and approaches that can help, and we really need to build in ongoing monitoring and assessment to make sure that we're always seeking to reduce and identify bias. And with that, I will stop and come off screen share. And I think we have a couple minutes for questions if folks would like. Thank you so much.
Love that. Eric, thank you for the overview and thank you for collating all of this and having some practical, like tangible suggestions and tips and tricks that people can apply later today. As a reminder, we want to assess our assessment expert. So please do click on the little grid rounds
Yeah,
evaluation.
I appreciate the feedback. Please let me know what I could do better to be helpful to you.
Yeah, we'll share. And there's a spot for, it's like 3 questions, but there's a spot for general feedback about the Ed Grand Rounds series or any other things that you're feeling. But one thing that we've had a little nerdy behind the scenes chatter on the Zoom chat function. We have a couple of different folks on here who are interested in AI and simulation and like avatar-based, faculty development. What have you seen kind of along those realms that has worked? If Ty and I were to join forces and she's the assessment expert and has all the data and I'm doing the faculty development, we're bringing in Clint, who's our ed tech guy. Where do you think we should start? And what have you seen?
So I think that's a great question. I think one of places to start is just to identify how you're doing, right? Take a look at your data and analyze kind of where things are. To Clint's role, I think there absolutely is an AI, and I didn't have really time to get in today. It's still relatively early, but I can tell you we used natural language processing to look at gender bias in narratives. And it turned out that, you can actually be pretty specific on what you can pick up as what kind of aspect of bias is involved. So I do think that moving forward, particularly with the kind of just incredible acceleration and capability the last 18 months, that I think AI is a really helpful tool, particularly in narrative, Clint, because you can tell it what to look for, right? You can train it to look for strings or particular words, even as a kind of low-tech way to go. But I would encourage you to kind of do that.
Well, even beyond that a little bit, I think we could train AIs to take on the personas of a whole range of diverse individuals and to be looking at assessments through those individual lenses, but at a scale of, 100 or 1,000 different individuals.
Yeah, exactly. Yeah, I actually talked to one of the authors of I don't know if you're familiar with the Google study DeepMind, the Articulate Medical Intelligence Explorer that was looking at diagnosis, and the Google doc did better than the real doc. Again, they use text, but he was basically pointing out exactly what you just said. We've got a whole bunch of narrative from our randomized controlled trial, and we're going to start applying AI to it and see if it can not only be used to identify problems or inaccuracies in the assessment, but also to use it as a feedback tool, right? So that, folks can actually, get real-time feedback that might be just generated through AI without having to go through all these other, traditional processes of analyzing data. So I do think there's a real potential here. It's early, but it just makes sense to me based on some early experience I've had working with the folks in this field. And then talking with others. I think you're right, Clint, there's a lot of opportunity.
Any other questions for Dr. Holmboe?
Love it, Ty. Thanks.
Perfect. Well, I know everyone appreciates a quick bio break before their next meeting. So since we just have a few minutes left, I'm happy to close it out. Dr. Holmboe, thank you for joining us. Thank you for kicking off the relaunch of our Ed Grand Rounds series. As a reminder, everyone who's here, we're doing these every month, second Thursday of the month, same time at noon, all virtual. And just check out the CU Academy Medical Educators website to see the full schedule for the 2024-2025 season. I think you'll be pleased with the variety of internal and external folks that we have joining us for this series. Don't forget to complete an eval so we can continue to learn ourselves and improve. And look forward to seeing y'all next time.
Thanks, everybody. Take care. Bye-bye.
Thank you.